Hey guys, welcome to the DarshanTalks recording and podcast. On this podcast, we discuss life science, legal, and regulatory issues, especially in the context of medical affairs, clinical research, and promotional compliance. If you like these videos and podcasts, please like, leave a comment, and subscribe. This video and podcast is brought to you by the Kulkarni Law Firm. Reach out to the Kulkarni Law Firm for advice on PRC review, MRC review, developing SOPs, training, audit compliance, and more. Reach out to Darshan at kulkarnilawfirm.com or call me at 302-252-6959. Or you can just visit our website at DarshanTalks.com or visit the law firm website at kulkarnilawfirm.com. That's KULKARNI lawfirm.com. Hey everyone, welcome to another episode of Darshan Talks. I'm your host, Darshan Kulkarni. I'm really excited because I get to have the one, the only Suzanne Kirkendall with us. And we've had her on before. And she is, as you can tell, very, very mindful about things like pronouns, which she has on her profile as we speak. I'm very excited to have her because she has been a champion of all things health. And she comes with a MPH background and with sort of informing us and telling us more about nudging and what that means and how it all comes together. But before we go on, Suzanne, you want to before we go on, the goal for today is actually talking about health equity. So we're going to talk a little bit about what it is, when it comes into play in the context of healthcare and life sciences, and how can nudging play a role. So Suzanne, I'm going to let you introduce yourself and we go from there.
Thanks, Darshan. It's very great to be back, and I'm excited for this topic today. So I am Suzanne Kirkendall. I am the CEO of North America at BVA Nudge Consulting. We're a global behavioral science consulting company. So we bring behavioral science to our clients across all industries, from healthcare to consumer goods to transportation, you name it. If there's somebody that you want to do something, we can probably help. As Darshan mentioned, my background is in more public health, health communication, health behavior change, both in the academic world and in marketing, and now in consulting.
So you're talking a lot about how you have various types of experiences, Suzanne. My question for you is, we decided to talk a little bit about health equity. What is health equity?
Great place to start. So health equity refers to giving everybody the same opportunity to live a really happy, healthy life. And it's important that we use the word equity and not equality, because we're not all starting from the same place. There are systemic things in place that make it harder for some groups of people than for other groups of people to live a healthy life in the same way. So equity refers to the fact that some people need a little bit more help to get to the same level of health opportunity than other people. If we say equality, that implies that if we just give everybody the same solution, they'll all have health equity. But if we're not starting from the same place, giving everybody the same solution is just going to keep you in the same disparate relative health.
So do you see this as an issue of personalization? Because you're sort of talking about addressing people for their different needs each time. So is that the same thing as personalization?
Ooh, love that. I'd say it's ideally, yes, it's personalization. So this is something that is a real hot topic in a lot of companies and organizations, is how do we communicate to people in a more personalized way, because we know that works better, or how do we design a more personalized experience? So when it comes to public health and things like health equity, generally we're thinking about things at more of a group or population level, because realistically, that's the way we can intervene most effectively. However, sure, the more personalized you can get, the better. But we know from all the research that's available and the research that continues to be done that there are patterns that are substantial and strong across different groups about the things that are making it harder for them to have their most healthy life. And so if we can address those patterns, we can help most people most of the ways. But of course, more is more.
So it's interesting you talk about personalization, and we talk about, as you said, starting from different points, and if you give people the same, you keep rising, and the difference doesn't necessarily change. But let me challenge you on that. I mean, are we talking a little bit about giving some people more and trying to demonstrate, if you will, equality in outcome, not equality in effort?
Yes. So it's more and it's different.
Okay.
Right. So some people, sure, some groups of people. So health equity is broad, right? So big project I've been working on recently with one of our partners is on disparities in Black maternal mortality and morbidity, right? So the US in general does not have a great maternal mortality rate compared to other comparable countries. But we know that in particular Black mothers, this is even worse than in, let's say, white mothers. And same with Hispanic and so on. So, but the reasons for this are different. So for white mothers and for Hispanic mothers, the issue for higher mortality is usually more around mental health. So you have substance use, suicide sort of things being part of the cause of that, postpartum mostly. However, for Black mothers, it's more a result of things like cardiac issues, leading to maternal mortality and morbidity. And that's a result of all kinds of things that have happened during the pregnancy and postpartum period through the health system and that whole experience, but also general life experience leading to higher risk of that in the first place as a member of this marginalized group. So they all need help, right? Because our maternal mortality morbidity rate is not good and we would like it to be 0%, right? But they need different help. And some people are going to need more help. So it's both.
So what do you say to those people who, and for some reason I've made you like the flag bearer, if you will, to explain health equity, but I'm sort of raising the typical issues that do get raised in this area. But what do you say to those people who say, look, some people, everyone comes with their own challenges. My goal is to treat everyone equally, and people will respond the way they respond. Why am I now in charge of making sure that the result is the same, not that the effort I put into it is the same, which is the only thing I can control?
Yes, love this question, because this is where the public health lens becomes really important, right? Because individual day to day, we're like, yeah, my life is hard too. Like I got to find time for the gym so I can keep myself healthy, and eating healthy is a pain in the butt and I'd rather not, etc. Right? We all have that to some level. So the public health lens reminds us that we are not individuals existing in a vacuum. We exist in communities, in organizations, in political systems. And these things also influence our behavior that we can control, but also they have an impact on us that we can't control, right? If you live in a community where there's a big highway that goes right by you, there are places in New York where there's a huge incidence of asthma, childhood asthma, adult asthma in these communities that happen to have a highway that go right by them, right? You can't really help that. So you have to keep in mind that it's not just about individual choices. It's about the system and the environment and the context in which someone lives that also hold them back. And so when we think about, well, you know, why should we invest extra effort in certain people, not other people? And it's because certain people are having more things imposed on them by the system and the context than other people. So white people like myself, we don't have the same racism issues that would be impacting day-to-day stress of individual interactions that can happen, things that can make it harder to get jobs that give you the opportunity to make the money that you deserve to make and have the benefits that you need to have to be healthy, and to access, you know, good doctors and doctors who take care of you in the way that you should be taken care of, instead of differences in treatment that we see based on race. Even though the doctor is the same, the patient's in front of them, the same issue, but if the patient looks different, they might get different treatment. So all these things have nothing to do with what you're choosing to do. And so when you have those things outside of you, you can't really blame the person for that when they have worse outcomes, right? So you have to say, okay, well, you've got more pushing against you. We need to give you more to push back with.
So what you're talking about is not necessarily giving them more, but trying to adjust for the differences so that we can have the same outcome. So it's not so much let's top them up. You're actually saying let's address the bottom issues, the baseline issues, so that everyone has an equal chance at success.
Exactly. There's a really fun comic that I think visually illustrates this quite well. And it's of people in a race. They're about to do a running race. And there's two people lined up at the starting line, same finish line. But one person is, depicted as like a white man. And his racetrack in front of him is clear and smooth, well paved, nothing in the way. The competitor next to him is a black person, and their track has a wall to jump over and some barbed wire to crawl under and a big mud puddle they need to navigate, and then they can get to the finish line. So, people will look at it and say, well, you're running the same race. What's the problem? We all have to work to be healthy, etc. in this case, but you're not actually running the same race. So it's a matter of, okay, there are those extra barriers in the way, even if you feel like, oh, we're all working towards the same result.
So let's talk about nudging. How does nudging help address these disparities?
Yes. So this is a case where I really like to reemphasize that nudging is one part of a large behavioral science toolkit. And nudging on its own is not going to fix this. I'm very, very transparent about that one because it's important. But nudging is an important part of the toolkit. So I'll expand to talk about behavioral science and how it helps with health equity, right? So some of how it helps at the top level are things like giving you that lens to say, oh, we understand we're not just individuals. We are people operating the system. So there's a particular model called the social ecological model. I shortened it to call it the onion because it looks like that when you draw it out. It's a lot easier to say. But basically it shows concentric circles getting bigger like an onion, and in the bottom there's individual, and then the next layer is interpersonal, which is all your relationships, and then there's organizational, which is could be doctor's office, could be your workplace, any organizations that affect you, and then there's the community, which is things like social norms, and then there's society and policy, so that's political system and rules, regulations, those sorts of things. So simple models like that are really helpful for us conceptualizing, first, what are the impacts on our individual health and behavior at the end of the day? Like we talked about, it's not just about you, it's about what's around you. But it also then reminds us all the ways that we can intervene and should intervene to help. Because I think a lot of people tend to default to saying, oh, I just need to tell people what to do and they will do it, or I need to just focus on the individual, and that's where I will solve this health equity problem. But because the health equity problem lives on all of these levels, you can't just focus on the individual to fix it. You have to look at these other levels and intervene in different ways so that you can actually start to move the needle there. So that's one big behavioral science tool. Then you start getting into, okay, I need to intervene on all of these levels of the onion, so to speak. Then you drill down into, okay, nudging, as well as a lot of other models and theories that are available, can help us design those interventions and then execute those interventions effectively.
So it's interesting you say that, because I'm comparing this to the different tools you've used before. And whenever I've talked to you about nudging previously, you reminded, I used to clerk for a federal court judge, and he would always go back to, what is the question being asked? What is the request being made? And it reminds me, nudging reminds me of that. What is the goal before we start designing something to fix that goal? So health equity sounds like the ocean. What are the questions that you have, like an example of a question that you faced that might be where we start? Like, I mean, even if you say it's things like, how do you address Black maternal mortality and morbidity, that's still an ocean of issues. Where do you go?
Yeah, it's a big one. It's a really big one, and it's a great question. And this is something that I end up spending a lot of time on when I'm working on a new project, whether that's for a client or otherwise. So when you talk about narrowing down the question, because I'm a behavioral scientist, I'm going to drive us towards not just what is the ask, but what do we need somebody to do? Not feel, not think, not be aware of. What do we need them to do? Because we know that a lot of people feel very nicely or think very nicely about health equity issues, but if they don't act on it, it doesn't make a difference. So our goal needs to be very targeted at behavior, first of all. And that behavior could be the behavior of the patient, could be the doctor, could be patient's partner, could be family members, it could be people in the doctor's office, it could be lawmakers. It can go at all of those levels. But at the end of the day, you are targeting behavior change. And that's the first thing that I always have to really drill down on and push people to think about, because it's not normally how we think about setting up the problem. We usually think more in the direction of awareness or attitudes or feelings. So that's number one. But let's talk about an example. So I mentioned earlier, I'm doing some Black maternal health work with a client. We have had the awesome opportunity at BVA Nudge to work with Wonderman Thompson Health, a big healthcare marketing network, on their health equity practice. And we have used Black maternal health as a pilot. And so, as you said, this is a huge question, right? Even though we've narrowed it down from health equity to one particular problem, it's a big problem with a lot of things going on within it. So what we've done to start to narrow down to develop interventions for this pilot, which we're in the process of doing, is we first just look at kind of the whole sea of research that's out there. And we say, okay, what even contributes to this? And what are the specific behaviors that are going on at each of those levels of the onion? So we literally lay out a giant spreadsheet with, level 1 of the onion, individual, level 2, interpersonal, level 3, organizational, community, and then society policy. And we go and look at all the evidence that shows, okay, what behaviors are happening at each of these levels that contribute to the health problem as it currently is. So it's very evidence-based, very rigorous. And from there, you can start to narrow down and you say, okay, from the literature, we can see that these 5 behaviors on the individual level are most contributing to this health problem. These behaviors on the interpersonal level are most contributing to the problem. And same thing for the rest of the other levels. And that includes the societal level. So it could be like lawmakers don't prioritize maternal mental health coverage in Medicare, whatever. Like it can be that level. And that's how you think about it at those higher levels. So once you've identified those, then you have a problem that's concrete to tackle, right? You say, okay, we know exactly how we've defined this health outcome issue, and we know all of the behaviors at all of the levels of that onion, the social ecological model, that contribute to that health problem happening. Then you say, okay, this was a very depressing research project. Let's take this a little bit more in a positive direction. We flip it and you say, okay, now we're going to make this logic model of change. So you make it all positive. So you say, okay, we're imagining the end goal of there are no maternal health disparities. The behaviors, therefore, need to be the opposite of what they currently are. So if someone's not doing something, if they do it, the logic is that will reduce the problem, right? So then you have your goal behaviors after you've already established in that first step your problem behaviors. So now you've got a defined problem to work on. And that's how you start to figure out what is the real ask here. But I'll pause.
That's amazing. So we start by sort of, as you said, in that specific instance, you started off by really looking at the social ecological model, dividing at that, and sort of, as you said, peeling each layer of that onion and deciding a component in that. And sorry, I'm just mostly summarizing what you said, but I'm making sure I understand this. So how do you find yourself working with different stakeholders, each of whom have different priorities, so that the end result is something that everyone is happy with when there are so many different competing priorities, even in something as defined as Black maternal mortality and morbidity?
How do we make everybody happy? That is a big philosophical question, my friend. Short answer is you don't, and you do your best, and then you do another project and you try to kind of cover all your bases somehow.
Fair enough. I guess what I was trying to figure out there, and that wasn't sort of
no, I'd
supposed
be
to be.
cheeky, I know.
No, I guess what I'm asking though is, like, and I'm comparing myself to like what I have to do in the law, right? In the law, I always have to go, okay, what is the question we're trying to answer? In your specific situation, you find yourself dealing with something a lot more obtuse and a lot more difficult to address. And everyone thinks that they have a stake in the outcome, which is a good thing. Mm-hmm. But if you don't go after the problem they've outlined, you find yourself possibly dealing with people who aren't your biggest champions anymore because they feel like their needs aren't being addressed. So if you start with policy, for example, that's great. That addresses something you need to do. That can probably be done as a combination, I'm making this up, but of marketing, advertising, and maybe working with lawmakers. But that suddenly makes the people who are at the individual interpersonal level feel left out. Mm-hmm. So it's that balance and sort of getting the stakeholders together. So how have you found yourself addressing that?
Yeah, really good question. So with this particular project, I find concrete examples helpful, so I'll continue with it. What we did is, after going through that whole initial, fact-finding mission of what's going on at all of these levels, we then said, okay, who are we? What partners do we have access to? Community partners, not just, BVA Nudge Consulting and Wonderman Thompson Health, but community partners that specialize in this. And then we say, okay, we can't boil the ocean. As you said, this seems like the ocean. We need to focus a little bit. So given who we were and who we had access to and what our resources were, in combination with identifying what's really important contributors to this problem, we said, okay, for this first pilot, because it's our pilot and we need to do a pilot-sized activity, we're going to focus only on the interpersonal level, because we feel like this strikes a balance of making a real impact and being effective on the problem, and within our wheelhouse of actually being able to be useful on this. So that's how we started to narrow it down, as being specific by balancing basically feasibility of us working on it versus impact on the problem.
Oh, that's really interesting. So this what you start off with. You start off with the question of what feasibility, if you will, which is interesting. I mean, there are 100 ways to address this. One of them could have been, what is the fastest issue you can solve, just to show quick wins, to buy into it. And again, you're not saying that this is the only way to do it. It was a concrete example that you dealt with recently that made sense at that time. So we've now got this situation of Black maternal mortality and morbidity. How do you see a situation like this in the context of, say, clinical trials? So in the pharma industry, one of the big issues you're dealing with is the idea of the FDA saying, we want more diversity, we want more representation in clinical research. And there's a lot of money, a lot of effort being put into it, because quite bluntly, the average population right now in clinical research looks like white men between the ages of 18 to probably about 45, 55. Again, no fault of theirs. And quite honestly, thank you for doing the research. But the research becomes less representative because it does not reflect women. It does not reflect minorities who may have different biologies, and quite bluntly, doesn't reflect older people who are probably going to be the ones taking the medication. So I guess my question for you is, how do you start and how do you begin addressing, using the lessons you're learning in this one section, how do you apply them to other sections?
Great question. So I'll add a caveat from my last point and then I'll answer this question. So I said we're focusing only on the interpersonal level. In general, I would recommend you focus on at least 2 levels, because there's not going to be any one silver bullet thing. As we talked about, these are multi-level issues, so you need a multi-level solution. But again, this is a proof of concept pilot, so we're starting with something feasible. So in terms of where does this stuff come into play for clinical trials and improving diversity in participants in clinical trials? So this is something that we've actually worked on in the past as well at BVA Nudge on the All of Us campaign at the National Institutes of Health, which the purpose of that is exactly this. It's to get more diverse people participating in clinical trials. And a lot of it comes down to meeting people where they are. So literally, like, what websites are people on? What physical places do they gather in the community? And where do we put actual posters up or have people go do a talk? Who is doing the recruiting? Where does this message come from? Does it come addressed from the NIH, or does it come addressed from their church pastor or their local primary care physician? You know, these things matter, even if the content's exactly the same. The messenger really matters. And then it's also making sure that you're speaking in a language that people can understand. Like, literally, is it in English? Is it in Spanish? Is it in Chinese? Is it, you know, that basic level stuff like that really matters. And then on a more systemic level, it's also improving actual access to participating in the clinical trials. Because another reason why we only have a certain narrow demographic participating is because these are also people who have the time and resources to go participate in these things. So the easier we can make it to participate, whether we're providing the transportation to them from the site or giving vouchers for the time off work, because if you take time off work and you have a job that pays by the hour, you're not getting paid. These sorts of things. So it's the communication and the targeting and the personalization, like we talked about at the beginning. And then it's also the bigger picture access and systemic things to make it more accessible as well. So it's still the onion, it just the specifics are different.
This was amazing, and we can obviously keep going, but we're already at our time limit. So Suzanne, before we go, any parting words?
I would say one more afterthought for the idea around how do we focus this and how do we make sure we have the right groups involved on the Black Maternal Health Project. We had very explicit discussions around not all people who give birth are women, right? You can have trans men, you can have non-binary people giving birth, but we purposely spoke to people in those communities and said, what do you think about how we should approach this? And the advice was, this is a very specific group that needs specific interventions. Cis women who are having babies are another specific group that you will approach differently. So trying to approach everyone in the same way with one overarching intervention is actually not going to be that helpful. So that was another way that we chose to focus. But just so people know, like, those conversations were had, and we did think about that very purposefully as well. That would be the last afterthought to add, I think.
Awesome. Thank you so much again. These conversations are not intended to be legal, regulatory, or clinical advice and may not be right for you. These conversations are intended for educational purposes only. Conversations on this forum do not create an attorney-client relationship.